So a pleasant day, dear doctors, and welcome to our Pharmacology Blitz. We will zoom in to the chapter in Katzung, as well as Goodman and Gilman's, particularly on the concept of the anesthetics. And I will be adding some pearls, respectively, for basically what you have to know for the board exam regarding the subspecialty for anesthesiology. So let's start the ball rolling and let's begin our high yield review. So everything begins with the concept of the different types of anesthesia. There are two types of anesthesia. First is the general. Second is the local anesthesia. Now, can anyone type in the chat box? What are examples of local anesthesia? What are the examples of local anesthesia that you have probably encountered or assisted? Now, yes, lidocaine is correct as a local anesthetic. Procaine is also correct. Bupivacaine is also correct. Now, as to procedure, what are the local anesthesia procedures? Not the drug, but the procedure. Okay. Tama naman that circumcision utilizes local anesthesia. Now, let me rephrase my question. Okay. What are the surgical procedures or the anesthetic procedures, rather, which is under local anesthesia? Okay. Now, we have spinal anesthesia. We have a subarachnoidal block. We also have epidural anesthesia. Yes, we have a field block. We also have a specific, for example, perineal block. Okay, pudendal or perineal block. Now, these are the classic local anesthetic procedures. Okay, now the surgical procedures, which would utilize local anesthesia, circumcision, incision and drainage, and yes, probably one of the most common would be the wound suturing. Now, I want everyone to memorize this concept because this will be applicable in the questions and clinical scenarios you'll be exposed to. Drugs with low solubility in the blood have a rapid induction time. Drugs with a high solubility in lipids have a high potency. Now, what is the significance if an anesthetic has a high potency? What is the significance if a drug, an anesthetic in particular, has a high potency? I want you to think well of what is the significance. Okay, so number one, very good. Always remember high potency drugs are lipid soluble. That means they can cross the blood-brain barrier. There is going to be a faster rate of induction. Okay, there's going to be a faster rate of induction. And of course, there's going to be a chance of more side effects. Okay, now, so again, low solubility equals rapid induction time. High solubility, which is lipid soluble, means high potency. So I want everyone to remember that. Okay. Now, drugs which are highly potent you will not have to use a higher dose. A lower dose is already potent. So toxicity-wise, okay, you have to consider the solubility of an anesthetic, okay? Now, I have to include this history. I have to include this history because this has been asked, okay? I want everyone to remember this drug, ether, okay? Ether was one of the most popular anesthetics used way back. So after 1846, this physician slash pharmacopoeia, James Simpson, introduced chloroform. Now, chloroform was a very, very widely used anesthetic. It is characterized as having a pleasant odor. However, it has toxicities. These significant toxicities involve the liver as well as the heart. It is a hepatotoxin, and it causes severe cardio depression. Okay, chloroform. Does anyone know where we use chloroform nowadays? When would we use chloroform? Okay, where would we use chloroform? In what situations would we use chloroform? Anyone? Chloroform is used as a diluent of several industrial products, construction materials. Okay, sewage is actually correct. Sewage is correct. Okay, chloroform is also used as a preservative. Okay, it's used as a preservative. And yes, it is used for cleaning materials. Now, question. What is the specific liver necrosis? What is the specific liver necrosis caused by chloroform? Specific histologic type of necrosis. Anyone? It is a centrilobular necrosis. So I want everyone to jot this down. Centri, okay, lobular necrosis. This is the specific type of necrosis caused by chloroform. Okay, specific type of liver necrosis caused by chloroform. Okay, please take note of this. Now, that is the important invention, okay, of James Simpson. Now, after the period of James Simpson in 1846, Edmund Andrews now came in, and there is now the introduction of gases. These gases were stored in cylinders. And one of the most important gases that were discovered or introduced by Edmund Andrews was cyclopropane and cyclobutane. Now, please take note. Both are flammable. However, cyclopropane is the one that is highly flammable. Please take note of this. So cyclopropane. Now, another thing I want you to remember, okay, as time passed, there was more discoveries. Okay, so we have Simpson, we have Andrews, and now we have the introduction of Halothane. This will come out in your board exam. The British Research Council, okay, introduced Halothane, and this totally changed, okay, it revolutionized inhalational anesthetics, because even up to this day, Halothane is utilized. Lundy, another physician, introduced thiopental. Now, question: between thiopental and Halothane, which is used in the lethal injection? Which is used in the lethal injection? Okay, very good. Lethal injection is thiopental. Okay. Which of these two, thiopental and Halothane, can cause malignant hyperthermia? Which can cause malignant hyperthermia? Okay, perfect. Malignant hyperthermia is highly associated with Halothane. Would anyone happen to know what is the other anesthetic that usually causes malignant hyperthermia? What is the other anesthetic, aside from Halothane, that is notorious for causing malignant hyperthermia? Correct answer is succinylcholine. Very good. So I want everyone to remember Halothane and succinylcholine are the two most important or two most common drugs that trigger or cause malignant hyperthermia. Now, one last, because I'm sure this will come out in your boards. What is the drug of choice for the treatment of malignant hyperthermia? What is the drug of choice for the treatment of malignant hyperthermia? It is dantrolene. Okay, now I know the examiners are aware you memorize dantrolene. My question is going to be simple. What specific channel is inhibited by dantrolene? What specific channel? Yes, tama naman yung calcium channel. But what specific calcium channel is inhibited? It is the ryanodine. Okay, ryanodine receptor. Okay, it's the ryanodine channel or the ryanodine receptor. This is how the board exams are. So please take note of this. Now, is anyone here aware who the chairman of the upcoming board exams is? Who is the chairman of the upcoming board exam? Anyone? Look in the chat box. That is the name of the chairman of the upcoming boards. And does anyone know what subject she used to be the chairman of in this government institution? Okay, it's pharmacology, specifically pharmacotoxicology. Okay, so heads up. Now, let's talk about general anesthesia and the elimination of general anesthesia. There are several factors that will determine how a general anesthetic is going to be eliminated from the body. Number one is pulmonary ventilation. Secondary is blood flow. And lastly is the solubility of that anesthetic, both in the blood as well as the tissues. Now, question. What diseases do you think would affect pulmonary ventilation? What diseases would affect pulmonary ventilation? Chronic obstructive pulmonary disease is there. There's also pulmonary tuberculosis. There's also bronchiectasis. Okay. There's also atelectasis. Okay, but atelectasis itself is not a disease. Okay. There's also pulmonary fibrosis. Now, question. This came out in the last board exam. What are the chemo drugs that causes pulmonary fibrosis? Give me the two chemo drugs. Dalawa yan. Number one is bleomycin. Number two is busulfan. Okay, bleomycin and busulfan. I like to remind everyone, okay, that B, breath, breathing. That's bleomycin and busulfan. They affect your breath and your breathing. Now, what is the antiarrhythmic drug that causes pulmonary fibrosis? Very good. It is amiodarone. The antiarrhythmic drug that causes pulmonary fibrosis. So make sure everyone jots this down and try to stretch while you can. Okay, stretch your arms, stand up, grab a drink. Okay. So please take note of this. Okay, amiodarone, bleomycin, busulfan. And I think something very important also that would affect pulmonary ventilation is the age of the patient and if they have a history of smoking. Okay, now question. If this is the lungs, okay, let's say this is the lungs, this is the apex, this is the base. Where is ventilation the best? Is it in the apex or is it in the base? Where is ventilation the best? It is the best here in the apex. Okay. Where is perfusion the best? Perfusion is the best at the base. Okay, so take note, this is GA or general anesthesia. What is the airway of choice if a patient undergoes general anesthesia? What is the airway of choice? How do we establish an airway if we give general anesthesia? Okay, it's endotracheal intubation. Okay, endotracheal intubation. Okay, that is why the lungs plays a very important role when we choose general anesthesia as our choice. Now, these are the pre-anesthetic medications. Okay, the concepts about pre-anesthetic medications. So these are the goals why we give a pre-anesthetic medication. Number one, we want to provide amnesia. We don't want the patient to remember. Next is for pain relief. This pain relief is for both pre-op as well as post-op. We also want to decrease anxiety without producing excessive drowsiness. The secondary goal is to minimize undesirable side effects, such as salivation, bradycardia, and vomiting. Question: what drug can we give to decrease the salivation? During pre-induction, okay, perfect. We give atropine. Okay, what does atropine do to the secretions, the oral secretions? Does it decrease oral secretions or does it increase oral secretions? Atropine will decrease the oral secretions. Okay, very good. It will decrease oral secretions. Now, what will atropine do to the heart rate? Atropine, what will it do to the heart rate? It will increase the heart rate because it's a sympathomimetic drug. Now, what drugs can we give for vomiting? Pre-anesthetic. Give me at least two. Give me at least two drugs which are commonly given as an antiemetic, and it's given pre-induction. So metoclopramide is used as an antiemetic. Promethazine is also used as an antiemetic. Ondansetron, which acts on the serotonin receptors, is usually reserved as an antiemetic post-chemotherapy rather than as a pre-anesthetic medication. Now, agents. These are the sedative, hypnotic, anti-anxiety agents. Number one on the list is really the benzodiazepines. Okay, now you have to remember that the examples of benzodiazepines would include diazepam, midazolam, lorazepam. Question: of these three, which is the long-acting? We don't want the long-acting, okay? We want a short-acting. Which of these is the long-acting benzodiazepine? Okay, the long-acting benzodiazepine here, it's going to be diazepam. Okay, diazepam is the long-acting here. Now, aside from the benzodiazepines, we can give barbiturates. Barbiturates are very good as an anxiolytic, but take note, it also sedates the patient. This can be given intramuscularly or this can be given orally. What should we watch out for if we give barbiturates intravenously? We need to watch out for the sensorium, and we need to watch out for the respiration. Okay, it can decrease the respiratory rate. It's a respiratory depressant. Now, what group of people, okay, is barbiturates contraindicated in? What special population? We usually test this with newborn screening. Okay, 1, G6PD, glucose 6 phosphate dehydrogenase deficiency, and patients who have porphyria. Okay, so please take note of this. Now you have to remember, especially the G6PD. Okay, especially the G6PD. Now, We can also give antihistamines, particularly hydroxyzine, as well as diphenhydramine. Now, can anyone tell me what famous brand is marketed in our country for hydroxyzine? It is an anti-allergy, it's an antihistamine. We can actually give it also as an anti-anxiety drug or an anxiolytic. Okay, very good. We have Iterax. Okay, Iterax. We have Iterax. So please take note of that. And of course, diphenhydramine. Okay, so this is an H1 blocker. Now, hydroxyzine is a very good anti-sialagogue. So it's going to affect salivation. It's also an anti-emetic. It is usually given intramuscular. One effect of hydroxyzine is also bronchodilation. Now, what antihypertensive can cause bronchoconstriction? What antihypertensive can cause bronchoconstriction? Okay. What antihypertensive can cause bronchoconstriction? Okay, very good. It is the beta blockers. Okay, it is the beta blockers. And you have to remember, not all beta blockers cause bronchoconstriction. Okay, it is the non-selective beta blockers. Non-selective beta blockers. So please take note of that. Now, what about the opioids? The opioids are very good pain relievers. They are usually given pre-op, and the classic opioids is morphine, meperidine, and fentanyl. Now, watch out for morphine because this can decrease the respiratory rate. Can anyone tell me the antidote for morphine toxicity? A classic pinpoint pupils of opioid toxicity. Pinpoint pupils. Now, we usually give Narcan or naloxone. Okay, we usually give naloxone. Now, if you are reading the book, the mother book, it's not just naloxone which is mentioned. It's actually naltrexone. Okay, naltrexone. Dalawa yan. Naltrexone and naloxone. Now, another effect of morphine is it's going to directly inhibit the cough center. So the cough reflex is going to be depressed. Okay, morphine. Now, next are the anticholinergic drugs. So the purpose of giving anticholinergic drugs is really to counteract the vagal effects of general anesthesia. And it will also lessen the secretions from the respiratory tract. These are the anticholinergic drugs. So be careful because there are vagal effects of general anesthesia. Can you enumerate what are the vagal effects of anesthesia? What happens to the heart rate? What happens to the heart rate? Okay, the heart rate will decrease. Okay, the heart rate will decrease. Okay, that is a vagal effect. The act of intubation and hyperflexing the neck can also trigger the vagus nerve. So that's something you have to be aware of. Okay, now I want everyone to remember this. Atropine, okay, when it is injected, it can cause dryness of the mouth within 10 to 15 minutes. What are we afraid of if there are a lot of oral secretions. I want to see if you understand the concept. What are we afraid of if there are so many oral secretions and we are doing general anesthesia? For one, it can cause blockage of the endotracheal tube. Okay, it can cause mucus plugging. And the most important thing is really aspiration. We are afraid of aspiration. Then we have scopolamine, which is superior to atropine when it comes to the anti-sialagogue effect. Now, can you give me one indication for scopolamine? Actually, it's the main reason why scopolamine is used. Scopolamine is an anti-motion sickness. Okay, it is given for motion sickness, anti-motion sickness. It's an anti-motion sickness drug. However, scopolamine is less effective in preventing reflex bradycardia. So since this is a difficult topic, I strongly encourage you to review the uploaded recorded video as soon as possible. Now, you're going to get one question here in your boards. What are the 4 stages of anesthesia? Okay, stage 1, analgesia. Stage 2, excitement. Stage 3, this is a surgical anesthesia. Stage 4, medullary paralysis, so breathing. So in stage 1 or analgesia, the patient is still conscious, they're still awake. However, there's going to be reduced sensations. Stage 2 is excitement, they can be combative here. This is when the BP goes up and they can be delirious. Now, this is what you have to watch out for, especially in cardiac patients. Okay, question. What is the drug of choice to treat surgical tachycardia? What is the drug of choice to treat surgical tachycardia or tachycardia which usually occurs during surgery? Okay, very good. Very good. It is esmolol. Okay, we give an IV beta blocker. Okay, esmolol. What about to decrease the blood pressure? There is hypertension during surgery. Give me 2 IV drugs that we can give. Esmolol is more of rate control. Elevated blood pressure, we have nicardipine. Okay, we can give nicardipine and we can give Isoket drip. Does anyone know what Isoket drip is? Isoket is actually the brand. What is Isoket drip? Okay, what is Isoket drip? Okay, that is isosorbide. Okay, isosorbide. Okay, Isoket drip is isosorbide mononitrate. Okay, the third stage of anesthesia is going to be surgical anesthesia. This is when the patient is unconscious, there's decreased vasomotor response, and there's now muscle relaxation. This is when basically the OR is ongoing already. Okay, medullary paralysis, this is important because this is when death can occur. There's now decreased vasomotor output, and this is when the patient can actually go into cardiac arrest. Okay. Now, for general anesthesia, I want everyone to remember the following factors which would influence the rate of induction. Okay, 1, solubility. We mentioned that earlier. We also mentioned pulmonary ventilation. There's now the partial pressure of the inhaled agent. This now depends, this is now different from one drug to another. The blood flow to the alveoli, because the alveoli is where the actual gas exchange occurs, and the arteriovenous concentration gradient. So please take note of this and refer to your study guide. Now, this is what we call the MAC. This is going to come out in your boards. What does MAC stand for? Minimum alveolar concentration. Every anesthetic has its own minimum alveolar concentration. This is the minimum alveolar concentration of an anesthetic drug, which is necessary to eliminate movement among 50% of patients who were challenged by a standardized skin incision. Now, tip, this is what you memorize for the boards. Anesthetics with a high MAC have a low potency. Anesthetics with a low MAC have a high potency. Now, question, which general anesthetic would most likely be used in the operating room right now? Is it a drug with a high MAC or a drug with a low MAC? What do you think would most likely be utilized? A drug with a high MAC or a drug with a low MAC? Which do you think would be used? Low MAC, high MAC, walang big MAC. Let's see your answers. What do you think would most likely be used? Okay, I see mixed answers here. Let's see your answers. There actually isn't a correct answer there. I'm just seeing where you're coming from. It really depends, because if you want a highly potent drug, you're going to use a low MAC, okay? But you have to remember, high potency is also associated, okay, with more side effects, okay? So it depends on who the patient is. Meron ba siyang comorbid conditions, okay? And you have to think of the surgical time also. You also have to think of the surgical time. Because we do not want surgical time or operating time which is long. So I asked, which would you choose as an anesthetic? A drug with a high MAC or a low MAC? Okay. Now, these are the common general anesthetics inhaled: halothane, enflurane, isoflurane, desflurane, sevoflurane, and nitrous oxide. Question, which of these inhalational anesthetics has the highest MAC? Which has the highest MAC? Okay, it is nitrous oxide. Now, interpret that. What is the potency of nitrous oxide? Interpret. Nitrous oxide has a low potency. In fact, of the inhalational anesthetics, it has the lowest potency. Now, which of the inhalational anesthetics has the highest potency? Based on the choices here, which has the highest potency? The highest potency is halothane. Okay, the highest potency is halothane. So please take note of this. Okay, again, please take note of this. Now, halothane, I want everyone to memorize this. Halothane sensitizes the myocardium to the effects of catecholamines. So what does this mean? This has to be used in caution in patients with cardiac disease. This can cause halothane hepatitis, which is a very deadly fulminant hepatic necrosis, and it causes malignant hyperthermia. So I just like to remind students, the halothane, halothane, ang daming side effects. Which drug? Halothane has a lot of side effects. Cardiac, hepatic, and it causes malignant hyperthermia. So please take note of that. Now, this is what you bring with you to the boards, and I really feel this is what's going to come out again. Nephrotoxic, okay, and we're talking about most nephrotoxic, is enflurane. Isoflurane is right in the middle. It is isolated. Nasa gitna, parang isotonic. It does not affect the cardiac output. It does not sensitize the myocardium to the effects of catecholamines. Desflurane, sevoflurane are similar to isoflurane. That is why what you notice nowadays is anesthesiologists using isodes or sevoflurane rather than enflurane and halothane. Has a better safety profile. Which of these drugs would you avoid in someone who is undergoing regular dialysis? Which of these drugs would you avoid in someone who's undergoing regular dialysis? Okay, very good. You should avoid enflurane. Now, situation. Which of the inhalational anesthetics would you avoid in a chronic alcoholic? Which of the anesthetics, inhalational anesthetics, would you avoid in a chronic alcoholic? Dapat iwasan mo yung halothane because it is hepatotoxic, it causes necrosis, and that's the last thing you want in a chronic alcoholic. Okay, now, nitrous oxide generally has no effect in the cardiovascular system. Okay, what is the MAC of nitrous oxide, low or high? What is the MAC of nitrous oxide? Is it low or is it high? Okay, low or high, the MAC. Okay, it has a high MAC. This is contraindicated in patients with a pneumothorax because nitrous oxide will increase the intrathoracic pressure. Okay, now this is what you bring with you to the board exam. Look at this GIF. What is the other name of nitrous oxide? A lot of dentists use this. What do you see? This is known as laughing gas. Okay, it is known as laughing gas. Now, tip, this is what came out in the recent boards. What causes diffusion anoxia? So write this down. Diffusion anoxia is caused. Okay, diffusion anoxia is caused by nitrous oxide. Okay, diffusion anoxia is caused by nitrous oxide. So please take note of that. Now, what actually is diffusion anoxia? This is also known as the Fink effect. Okay, again, this is also known as the Fink effect. So this is the principle wherein whenever nitrous oxide is given, hypoxia can occur. Now, always remember nitrous oxide can diffuse in air-containing cavities faster than nitrogen diffuses out. So what happens is the intrathoracic pressure will increase. Okay, the intrathoracic pressure will increase. So please Take note of this. Now, I want to isolate propofol. I have a gut feeling this is going to come out. You've probably encountered this during your hospital duties. So, one thing good about propofol, it has a very better recovery, okay, compared to other induction agents such as thiopental. That's why it's used a lot. Okay. Now, this might come out because this is lifted from your textbook. What is the most common side effect? What is the most common side effect of propofol? It is pain at the injection site. Okay. Pain at the injection site. Please take note of this. Pain at the injection site. I hope you got this. Now, I want to introduce to everyone that propofol is commonly marketed as Diprivan. Okay, that's a common brand which is used worldwide. Okay, Diprivan. Please take note of this. Now, what is the advantage of using propofol? Propofol causes decreased levels of consciousness and a lack of memory for events. This is what we want. We want a rapid induction and the patient is amnesic after. Look at the onset of propofol. It's very fast, within 15 to 30 seconds. Duration is 5 to 10 minutes. Okay, duration is 5 to 10 minutes. So please take note of that. Okay, again, please take note of that. Very, very quick onset. Now, does anyone know who's the most famous celebrity who died of a propofol overdose? The most famous. Okay, sino siya? Okay, the king of pop, Michael Jackson. Okay. King of pop. Now, something else I would like to add to propofol, because this is how very specific the examiners are. They love asking about receptors. Now, always remember there's a GABA A, there's a GABA B receptor. Question: what is GABA? Is GABA inhibitory or excitatory? What is GABA? Is it inhibitory or is it excitatory? Okay, always remember GABA is the most common inhibitory or most abundant inhibitory neurotransmitter in the central nervous system. Question: what is the most common inhibitory neurotransmitter in the spinal cord? What is the most common inhibitory neurotransmitter in the spinal cord? Very good. It is glycine. So where does propofol act? It acts on the GABA A. Memorize that. You have to specify GABA A, not GABA B. Where do barbiturates act? Where do barbiturates act? GABA A or GABA B? Saan yung barbiturates? Okay? Barbiturates. Where do barbiturates act? Okay? What receptor? Okay, is it GABA A or is it GABA B? Now take note, it is predominantly GABA A. Okay, predominantly GABA A. Yung barbiturates. Now, I want everyone to remember this. Okay? What are the warnings of Propofol? Number one, it is susceptible to bacterial growth. That means the vial has to be discarded or thrown away right away. In fact, the box warning is within 4 to 6 hours. Next, it can cause shock or hypotension. Okay? Now, your assignment is to read on prolonged Propofol syndrome. I'm going to include this in your quiz, which I'm going to be uploading. I'm going to be uploading some quizzes which are not on the schedule so that you can study right away from recent topics that we've been taking up. This is most especially for our sections, Hiraya, sections Savior, sections Tesla. Those from other sections may access the online exams, mga quizzes about the recent topics, if you want to practice. So don't forget this. Propofol is notorious for causing shock. Okay? And we already mentioned the pain at the site. So let's finish up on the last drugs. Okay, again, opioid toxicity is going to be taken up under toxicology. Now, ketamine. I want everyone to remember, ketamine is usually used in trauma cases. Now, this is the one that came out in the recent boards. It causes dissociative amnesia. It is a dissociative anesthetic. Okay. What causes the diffusion anoxia? Are you still with me? What causes the diffusion anoxia? Diffusion anoxia is caused by nitrous oxide. And what is the dissociative anesthetic? What is the dissociative anesthetic? I'm swearing on my license. I'm swearing on my life. This is what's going to come out in the boards. The dissociative anesthetic is ketamine. So what is this state of dissociative anesthesia? It is a state of catatonia, a state of amnesia, a state of analgesia without loss of consciousness. So the patient is wide awake, they cannot move, they are paralyzed, they are catatonic, and they can't remember anything, and they are pain-free and relaxed. That is classic ketamine, dissociative anesthesia. Now, ketamine can also cause nightmares. Now, we mentioned it's used in trauma cases, but ketamine should not be used in head trauma cases because ketamine can increase the ICP. I want you to master these principles I've lifted from the mother textbook. And when you take these exams, I'm going to prepare for you higher level of learning, just like what it is in the syllabus for the PRC. You're going to get cases and you're going to decide which anesthetic to use, which anesthetic is the culprit, which anesthetic should you avoid. That is what's going to come out in your boards. Okay, so this is your guru guide. Ketamine is the dissociative anesthetic. Okay, now let me insert benzocaine. This is a local anesthetic. It's an ester local anesthetic. It blocks sodium channels. Now, always remember, your local anesthetics, the ester types, they will block sodium channels and nerve conduction. Be careful because benzocaine is a topical anesthetic. It causes irritation of the skin. It can cause pain, it can cause itching, and it can cause inflammation. Pain, itching, and inflammation. So please take note of that, okay? That's benzocaine. Now, take note of this. Anesthetics are either esters, local anesthetics are either esters, amides. Always remember, allergic reactions are more common in esters. Okay? Always remember that. Classic esters are procaine and tetracaine. Classic amides is lidocaine, which is the most widely used local anesthetic, mepivacaine and bupivacaine. Okay? Please memorize that by heart. Which of these local anesthetics is also an antiarrhythmic? Which of these local anesthetics is also an antiarrhythmic? Okay, very good. Very good. It is lidocaine. Now, your reading assignment is to read and memorize what is the toxic dose of lidocaine. Again, what is the toxic dose of lidocaine? Now, I want you to remember this concept regarding local anesthetics. When there is an infected tissue, it's going to be acidic, okay? More anesthetic is needed because that anesthetic, that local anesthetic cannot penetrate that membrane effectively. Now, can you explain to me why infected tissue is acidic? Why? Bakit acidic yung infected tissue? Inflamed and infected tissue. That is because when there is an infected tissue, an aerobic glycolysis occurs rather than aerobic. And what is the end product of aerobic glycolysis? Very good. Okay, it is lactic acid or lactate. Okay, so there is anaerobic glycolysis because this infected tissue is usually going to be invaded by anaerobes rather than aerobes. It's really the lactic acid. So you need to add a little more. Okay, now, bupivacaine, almost done, is a local anesthetic. This is an amide. Also blocks sodium channels and nerve conduction. Question, where are allergies more common, amide or ester? Where are allergies more common? They are more common with esters. Okay, now, bupivacaine has several regional as well as local indications. Obstetrical surgery, general surgery. You can use it for diagnostics as well as therapeutic purposes. Now, tip. This is what's going to come out in your boards. The most cardiotoxic of the local anesthetics is bupivacaine. Okay? The most cardiotoxic is bupivacaine. So this is your take home. Bupivacaine is cardiotoxic. Okay, that is what I want you to memorize. Okay, are there any questions?